The most common cause for a scaphoid fracture is from a fall onto an outstretched hand. It is the fracture of the cortical and trabecular bone of the scaphoid.
Human carpus consists of 8 small carpal bones arranged in proximal and distal rows that articulate with the heads of radius and ulna. The scaphoid is the largest bone located in the proximal row, articulating with the radius, trapezoid, trapezium, lunate, and capitate. It's a boat-shaped bone consisting of proximal pole, the base, and the distal pole. Most common scaphoid fractures occur at the base due to excessive force. However, they can also occur at the proximal or distal ends of the bone. These fractures occur in 2 different ways, known as either non-displaced, where bone fragments are lined up correctly being in their normal position, or displaced fractures, where bone fragments don't line up correctly and have displaced out of their normal position. Scaphoid fractures account for 71% of all carpal bone fractures, resulting in pain and swelling in the anatomical snuff box and cause interference in the gripping motions of the hand.
Many modalities are used in the diagnosis of a scaphoid fracture. Clinicians suspecting a scaphoid fracture often request plain radiographs for initial diagnosis with a standard 4 series films in posterior anterior, lateral, oblique, and ulnar deviated PAs to determine if the patient is positive or negative for a fracture. While this may be useful if positive, follow-up radiographs cannot exclude fracture and further investigation, with an MRI is generally used in the case of high clinical suspicion, or a CT scan if early MRI is unavailable or not compatible with the patient, for example, if they have a metal implant. In a plain radiograph, the following anatomical structures are present. However, some structures are subjected to superimposition. The scaphoid appears as a radiopaque boat-shaped bone located lateral to the lunate in the proximal row of the carpal bones. Similarly, on a CT scan performed using the bone window, the following can be observed. The scaphoid appears radiopaque, similar to the radiograph. An MRI can be very sensitive when looking at edema, which has occurred after a fracture, and also sensitive for ligamentous injuries. The T2 MRIs generally have an increased signal in edematous bone marrow. The following structures are also visible in an MRI.
It is important to mention that MRIs, CTs, and plain radiography all have the ability to produce a clear image of a scaphoid fracture. However, plain radiography has a suggested rate of 15 to 20% being missed on the first image, and repeat plain radiography 10 to 14 days later can be used to diagnose via evidence of remodeling. We focused more on the availability of each modality and the cost involved, and concluded that plain radiography with a secondary scan 10 to 14 days after the original is the best method, as it is readily available, mobile, and cost effective. The 10 to 14 day waiting period is necessary for visualizing remodeling, as many scaphoid fractures are misdiagnosed as bruising. This is because patient pain for bruising and scaphoid fractures are similar. Follow-up plain radiography is not always performed, however it is a good way to improve diagnostics for scaphoid fractures, as well as MRIs to look for edema of the bone 10 to 14 days post-injury.
In this plain posterior anterior radiograph of the right hand, the scaphoid bone can be seen in the proximal row of the carpal bones. It appears as a radiopaque, large boat-shaped carpus bone on the radial side of the lunate. The waist of the scaphoid bone makes up for approximately 70% of all scaphoid fractures. This type of fracture is referred to as a middle third fracture. In this radiograph contrasting a healthy patient with a patient that has a non-displaced middle third fracture, the fracture appears as a semi-radiopaque, small, thin line located inferiorly to the scaphoid trabecle. In a healthy patient, the scaphoid bone will remain radiopaque throughout. A fracture will usually appear semi-radiopaque or radiolucent, depending on the size of the fracture and if any superimposition happens.